Well, you can do the math and you can see, okay, well, that's a bump and that's a step in the right direction. And of course, doing all the right stuff, eating right, sleeping right, training right, choosing your parents right, can help you up until a point at which Mother Nature takes over and says, no, you're done. And then you have to rely on other methods.
Welcome back to another episode of the Peak Performance Life podcast. And today we have a very special guest named Rand McClain. And Rand runs the Regenerative and Sports Medicine clinics. He's also the author of an upcoming book called Cheating Death. And he's an expert in all things anti-aging, using cutting-edge treatments in his facilities like stem cell injections, hormone replacement therapies, all sorts of things that help you live longer, but not live longer in a way where you're just, propping you up and staying alive, living longer in a way where you are healthy, you are strong, you are fit. Some of you are listening via audio right now and can't see Dr. McClain, but he is 60 years old and looks incredible. He's incredibly fit, looks amazing. So he's actually walking the walk, not just talking the talk. So it's a real pleasure to have you here. Thank you for joining us.
Thank you for having me, and very kind of you. Thank you.
Well, great. Let's jump in with maybe a quick background of how you kind of got to where you are today and got so interested in a little bit about your journey, kind of the short version.
Short version is that I have to give credit where credit's due. My mom was someone who was interested in nutrition long before anyone else was. And she had a collection of books, one of which was interesting to me, Adele Davis, when I was 11. I don't know what possessed me to pull it off the shelf. I was bored, or maybe I was sick at home. But anyway, was fascinated by the fact that we can control aspects of our health through nutrition. And that just caught my attention, and I followed in her footsteps. And we used to eat wheat germ pancakes. Didn't like it back then, but I'm very appreciative now that I realized how important it was for me, and what a great thing she did for us. But then, I went through my life and participated in sport and had a lot of sport injuries. I wanted to become the best in sport that I could, and of course, keep my general health up. And so I kind of learned by having to go through a lot of this stuff. And then I figured, you know what? Actually, I was about to be a father, and I said, yeah, I got to settle into a career. This happens to be my ninth one. I was an accountant for a while. I did a lot of other stuff. And then I said, what do I really want to do? And then I settled in medicine because it just made sense to me. And it has worked out very well, having been through a lot of the stuff that I have to address with other patients.
Yeah. And I know you've been an athlete in the past, and so you've kind of practiced and trained professionally over the years, yeah, we'd be curious to kind of hear if you're still, what your training regimen looks like these days as well.
Oh, heck yeah, man. Never stop. I always say exercise is the great equalizer. It's one of the most important things you can do. Last May, my wife and I, we climbed Mont Ventoux, and now we're kind of hooked on the French mountains, I guess you might say. So we're planning for an Alpe d'Huez ascent this year. And so we do a lot of biking, and like to hit the heavy bag. That's always good. I got the bag out after COVID hit and the gyms were closed. And besides that, I've been playing tennis since I was 5. My wife loves it, so it's another opportunity for us to do stuff together. And then, now that the gyms are open, we get to the Mecca here at Venice, Gold's Gym, every now and again.
Oh, nice. So that's where you're at in Venice, and you get to hit the famous Gold's Gym there.
Yeah, no, I've been doing it. I've been there since '86, and it's gone through a lot of iterations. But I like to say you can never have a bad workout there. It used to be when we first came out here, two blocks away, you could hear the music jamming. Everyone was having a great workout, and if you were having a bad day, it didn't matter, because as soon as you walked in there, you were so inspired that you just had to step up to the plate, and you had a good day no matter what, even if it wasn't a great day. But yeah, it still carries the same atmosphere about it. It's different, but it's still great.
Amazing. Yeah. And I was going to say, I could tell you're definitely lifting weights. So I knew that one. I know hitting the bag and bike riding and climbing mountains, but I know for sure you're lifting weights too. I could tell just from looking at you here. So looking amazing for 60. I'm sure you're putting most 30 and 40-year-olds to shame, even 20-year-olds. Yeah, so let's jump into a little bit about I guess let's start with a little bit of like the most common work that you're doing with patients in your clinic. So obviously you're having people, a lot of our listeners are actually in their, 40s and 50s. They don't recover the way they used to. It's a challenge for myself personally, right? Like I would actually like to lift heavy weights a lot more than I do. But it's the recovery that really gets me these days. Love to hear your thoughts around that.
Well, depending upon the age, there are different factors involved, but for the most part, most of what hits us, I relayed, when I was about 48 is when I say Kong jumped on my back and asked me what the heck I thought I was doing, working out like I did when I was 30 or whatever, just like you're talking about. And I'd say most of it up until we reach the maybe 50s, 60s, and again, everyone's different, is what happens to us sometimes gradually, sometimes a little bit more abruptly, but a loss in hormones. Specifically, the steroid hormone, meaning made from cholesterol, testosterone, for guys and gals, by the way. It's the same in terms of effect for both genders. You don't have the leverage, I call it, and I choose that word carefully, anymore. So the stuff that's been working well for you, from the 20s and 30s, all of a sudden doesn't work anymore. And then, of course, what do? You step it up. You say, okay, well, I'm going to work out harder. I'm going to add an extra day. I'm going to cut out beer and pizza, so I can stay slim. And none of it's working. Why? Not because you're not doing all the right stuff. It's just you don't have the leverage. So most of what I do here, and certainly some of the most rewarding stuff that we do here is, getting those hormones back up to where they should be, something that would give you the same energy and results as long as you're doing everything the right way as you had when you were 20. And that makes me happy. You can see how I might have a great job when people, 6 weeks after they start therapy, come back and you can start hitting your personal best again.
Yeah, that's amazing. You mentioned, and so it is a very hot topic these days, right? Hormone replacement therapy. Within hormone replacement therapy, obviously testosterone is probably the most common. And you mentioned for men and women. So is also women going on testosterone replacement therapy? And then I'd also love to hear you talk about what are some of the wrong ways to do it that people are going about it, or some of these, online clinics where you can just, I know there's websites where you can just, go fill out some information and they send you testosterone or whatever. What are some of those ways that you're seeing people doing it the wrong way, and what's the right way to do it?
Well, first of all, men and women have the same hormones, just different amounts, different ratios as well. And the results are the same. In other words, it's for the same benefit that, again, we have testosterone for energy, libido, sense of well-being, body composition changes, such, typically people want more muscle and less fat, right? And again, it leverages those. So absolutely, women depend upon testosterone just like men do. Men also depend upon estrogen. Okay. We can't just bury estrogen because it makes us look fluffy or something like that. We have to have a certain amount for brain health, for heart health, for joint health, but certainly, again, much less than the female. So the key is just knowing what those amounts are for each individual and replacing them as necessary, and getting back to what you had, typically something close to at least in effect what you had in your 20s. Now, when it comes to how to do this, you hit upon a sore spot. There are a lot of clinics out there that don't do it the right way, whether it's medically speaking and even, unfortunately, legally speaking. The Ryan Haight Act really shut down a lot of these clinics that are being used to really just dole out almost like a pharmacy. Well, not even like a pharmacy, but doling out meds and not even seeing a doctor. And that runs a lot of risk. Although, I would say that fortunately, this type of medicine runs few risks. I don't know if there's even what they call a lethal dose 50 of testosterone or estrogen or pregnenolone or any of these other, again, steroid hormones, because they come from cholesterol. But, still, you want to do it the right way. You want to do it as safely as possible without side effects. And certainly I've employed telemedicine since long before COVID, but you have to follow the guidelines. If someone is not speaking with you, who's a physician, whether it's a nurse practitioner, a physician's assistant, a DO, MD, then, I would tend to suggest you run away.
Hmm.
You don't want to deal with a salesman who happens to have a little bit of knowledge about this sort of thing. And I think that's obvious. But by law, I believe in all 50 states, you have to establish a patient doctor relationship through that history taking. And it should be thorough, obviously, and a physical exam. Now you say, well, how do you do that with telemedicine? Well, you can rely upon the physical exam of a qualified doctor, nurse practitioner, another practitioner, just like you would in any sort of consultancy relationship. That's allowed. So yeah, if you're talking to a group that's not following those guidelines, then you probably want to try another one.
Got it. Got it. And what about so let's say most people have gotten a blood test done. Well, I shouldn't say most people, but most people should at least get a blood test done to see what their testosterone levels are, their different hormone levels, if there's any vitamin deficiencies, things of that nature. What would you say is, and then within testosterone, it's interesting because I hear most people only talking about their total testosterone number, but recently I'm hearing a lot more that it's actually the free testosterone number that may be kind of more of the important one. I was just curious your thoughts on that, kind of like which one do you think is more important, free or total testosterone?
If I had to choose, I'd say free testosterone because that's where the rubber meets the pavement. That's what's available for use. But I would argue they're both important because you may find that part of the problem is not that your body's not producing enough testosterone, but it's not making enough available. So you have enough of, and without getting too far into the weeds, and stop me if I do, certainly, but sex hormone binding globulin is what keeps it as potential. And if that is too high, then your actual free, meaning free of that binding hormone, testosterone is not available. And maybe it's just a matter of, increasing your protein intake or reducing your estrogen, both of which tend to reduce your sex hormone binding globulin and make more testosterone available. So you don't have to jigger the total. But yeah, until fairly recently, we measured and depended upon that measurement of total testosterone to guide us. But something you said before that I wanted to address too. Gosh, I lost my train of thought.
Free testosterone, regular testosterone, and then I was going to also get into asking you about what levels are, let's say, for a normal 45-year-old male. Would you be concerned with what levels are there specific levels that people should really think about doing hormone replacement, or is it more how they're feeling? Is it like, for me, I've always thought about, well, my total testosterone, I think on my last couple of tests, I was like at 890 and then like 780. So I was like, okay, well, as long as I'm over 600, I'm going to try to, hold off as long as I can. I know eventually I'm probably going to go on it, but if I'm over that number, but then my free testosterone, I think was like 11, or depending on how it's measured, 111 or 11. And then that's one that I wish was a little higher. Kind of curious what your thoughts are on kind of those numbers. I'm 41, actually, almost 42 at this right now, but curious what you would think about those numbers for like a 40 to 45-year-old male.
Well, you reminded me, because it's connected, about what I wanted to mention that you mentioned earlier about getting these numbers. Okay. Yeah. In short, the numbers are really secondary to a large degree to whether or not you have signs and symptoms of low testosterone. I would argue, though, and it sounds perhaps a little bit contradictory, that to your point that you mentioned earlier, it'd be great if it was part of a standard laboratory assay for a physical exam, because it would be nice to know, hey, when I was feeling great, whether it's at 25, 35, and my level, to see what my testosterone levels were. And see if it's now commensurate or not. And it just helps with the detective work of deciding, hey, is the reason why you're tired all the time because you have low testosterone, or it's because you're working 3 jobs? And that's
Right.
not the issue, or some other thing that we need to address, like maybe hypothyroid. To your point, though, and I think I already touched upon it, but to elaborate, people don't typically get up in the morning and say, well, gosh, I wonder what my testosterone is. I better go in and see the doctor right away. They wake up feeling tired or with decreased libido or maybe depressed. Testosterone happens to be nature's antidepressant. And then they go see the doctor, or they do some research with Dr. Google. And then they say, well, oh, maybe it's testosterone, and then go in and maybe look for that assay right away. But again, to your point about total, that's part of the story. Your numbers, if I may, 800, 900 total. And yes, there's a discrepancy between, LabCorp and Quest, for example. There's a decimal point issue there. And I won't go into that. But anyway, let's use LabCorp, for example. If your free T is normal in terms of its percentage, it'd be about 2% of your total. Well, 11 is not 2% of 800 or 900, right? So yeah, we might look into, despite your nice production of testosterone, why is it not free and available for you at something a little bit more commensurate with, normal, whatever that means,
right,
for the average person in this case? Because that's what's real to you. And I would say at 11, I would look to other things like, again, the primary concerns that you came in with, primary complaints. Are you, and you can't say, am I tired, so much as, do I have a decrease in energy compared to me 10 years ago? Because if you say, am I tired, and you compare it to somebody around you, who's naturally bouncing off the walls, well, that's not fair. And same with the other way around, which oftentimes makes people delay coming into the office because they go, well, gee whiz, man, I'm doing pretty good. I mean, I'm not like my buddy Jim, who's fat and out of shape on the couch. I must be okay. And it must just be because I'm getting older, or it must just be because, I'm staying up too late, and maybe I should stop that. And you don't, of course. So you get my point. It's you relative to you. And if you do have a decreased energy, decrease in libido, decrease in a sense of well-being, sometimes cognition can be affected, then yeah, it would be worthwhile going and getting these things assayed to see if that's indeed what might be the source of the problem.
Yeah. And it's a really great point you mentioned. I imagine in 100 years from now, they'll be like, man, these people didn't keep track of their, free and total testosterone, as well as, 100 other markers from the age 20 all the way through, 100 years old or whatever it is. Right. Cause like you said, like, I bet you could ask, 1,000 people, who are in their 40s, what was your testosterone numbers when you were in your 20s? And maybe only a couple of athletes who were trained under doctors, professional athletes, maybe one or two of them out of 1,000 might know what it was. But again, pretty much nobody knows what their numbers were. So they don't really have a baseline of what they were at in their 20s. So then we're just kind of guessing. And that's interesting. But yeah, I also agree with you. I'm like trying to get my free testosterone number higher. And I know you mentioned eating more protein could be one of those ways. Is there any ways kind of naturally, before I would have to go on hormone replacement therapies, what would you recommend maybe for me to try to get the free testosterone up naturally, in your opinion?
Well, again, eating more protein, getting your estrogen, and we typically use estradiol sensitive, by the way, because the other assay of just serum isn't going to be precise enough to be accurate for such low numbers that we tend to have in our system as males. But there's a tipping point I've observed somewhere around maybe 21 to 22 picograms per milliliter of estradiol. Again, we use that as a surrogate for all estrogens, under which if you get to that, your SHBG tends to drop and your free testosterone rises. Also, and don't ask me how we figure this one out, but stinging nettle is an over-the-counter supplement that can be used to lower SHBG. Other than that, you're going to be talking about drugs that would help you lower SHBG, as far as I know, at least at this point. So those are the basic ones. And of course, getting your total T up would also effectuate a change, presumably in your free T, even though the percentage might be the same. If you got, if you were 1% and you went from 500 to 1,000 total T, well, you can do the math and you can see, okay, well, that's a bump and that's a step in the right direction. And of course, doing all the right stuff, eating right, sleeping right, training right, choosing your parents right, can help you up until a point at which Mother Nature takes over and says, no, you're done. And then you have to rely on other methods.
Right. And what I know a lot of people, including myself, have some concerns about, once because in my mind, and maybe I'm wrong on this, but I'm thinking to myself, Well, I'm trying to postpone it as much as possible because once I start, then I'm pretty much gonna shut down my normal production, and I'm gonna always have to take it. And so I'm kind of like trying to do my best to to stay I guess natural, I guess, for to a certain extent. And then I guess that leads to another question after is like, what levels are too high, right? I know some, I recently spoke with someone. I said, oh, what's your testosterone? You're on TRT? And he said, yeah, I'm on TRT. Oh, what's your number? He said, oh, I'm off the chart. It's like 1500 is like as high as the chart goes on mine, and I'm higher than that. I'm off the chart. And I'm like, okay, isn't that too high? Like, I don't know if he's doing it under supervision or what, right? Obviously, when we were younger, we had those guys in the at the gym where clearly they were doing things not under supervision. I don't even think they had clinics at that time. So yeah, just kind of curious your thoughts on all that.
Well, in terms of let's start back where you started, which is, there is a tendency, I find, that a lot of people want to stay as natural for as long as possible, right?
Mm-hmm.
And that's, I'm a registered libertarian, but there's a part of me that, just because I see it in my office all the time, where people are like, wow, I wish I had done this earlier. Because yeah, it's also natural to get sick and die one day. So I'm not necessarily enamored with natural if we have a better way that doesn't rob Peter to pay Paul. And I would argue that you don't. And then there's the idea that, oh, well, now I'm dependent upon this. Well, okay, but you're also dependent upon air and food, and and there's certainly nothing natural about going to the gym and pushing iron around, right? I mean, some of the stuff we do. And so again, I'm deferent to everyone in that regard, that, to each his own. But I would argue that if you're suffering from some of these symptoms and signs of what we call hypogonadism, whether it's a woman's ovaries or a guy's testicles, then yeah, consider it. And yeah, are you going to be on it for life? Not because you're dependent upon it at all. You can go off it. And just like a girl who's on birth control pills, for example, where she's using them for contraception, obviously, and she's jiggering her own hormones, lowering them, okay, for a purpose. When she goes off them, sometimes within a month, certainly 3 months typically, they've reequilibrated. Okay. Now, they're not necessarily going to be the same levels as when she was 20 if she gets off at 30. And the same thing happens with guys, though. You're going to stymie your own production of testosterone, for example, if you use TRT. First of all, though, if you're in for the right reasons, your testosterone is low to begin with. So what are you really stymieing? Who cares, right? But right. To follow it out to its natural, conclusion here, or the point I'm trying to make is that if you decide for whatever reason you want to come off it, it'll come back. Now, it's not going to come back, just like with the example of the female, to what you had when you were 30 if you get off it at 40, but it will come back to your normal 40-year-old level. Okay, so that's the first point I want to make. The second one is testosterone is unique in the way it works in the body. And it's not like thyroid, for example, where you're looking for a sweet spot and you don't want to be too high or you don't want it to be too low. You're actually, with testosterone, looking for a therapeutic minimum above which you want to stay. Okay, it's not linear in its effect. You got to hit that mark. Otherwise, you'll say, well, this stuff doesn't work. But once you hit that mark, it can become a little bit linear, where you go, oh, a little more and I feel better, until you get to a point where they call it your saturation, your androgen receptors. There aren't any more of them to be hit by testosterone. So it's like adding more oil to a car that's got plenty of oil. Right. As long as there's enough for each combustion, adding an extra quart, you're just carrying around an extra quart. Who cares? But with testosterone, the reference intervals go right out the window when it comes to replacement therapy. And we've known this since the 1950s. And what's really interesting to me, and I'm a nerd, so stop me if this gets too uninteresting, but for guys, I would say take the upper limit of the reference interval, which used to be like 12 something, or no, 11 something with LabCorp. Now I think it's like 9 something, but multiply it times about 1.6x. So we're getting to that 1500 number, right? And that's typically, if you want to get the maximum benefit, where you have the most resolution of symptoms, where you're going to want to be on the day of your next application. Okay, meaning that's the lowest. Okay, and to relate that to free T, if you use the LabCorp 2% rule, that's 30 picograms per milliliter of free T. That's a lot. But again, we've seen that since the 1950s, and we used to use total T as a guide because we didn't know any better. we've just observed that you had to go to that level to see a resolution of symptoms. For gals, this is what I think is cool. We say, well, testosterone's for men and estrogen's for women. Well, for women, I find you have to go to about 3 times the upper limit of normal, the reference intervals, to get the benefit they're looking for, again, resolution of symptoms. Now, beyond that, okay, I'm talking about a therapeutic minimum. We say, well, is there a maximum? Not in the sense of that, lethal dose, but certainly then you deal with the metabolites of excess testosterone, and you don't want to have to deal with that if you don't have to. So dihydrotestosterone, estrogen is a metabolite of testosterone. That's a good reason, 2 really good reasons why you don't want to just go, well, let's just go for double the dose and hope for the most, because you can have some consequences that way.
Yeah, we all kind of, well, maybe I personally know, I grew up in Queens, New York, where it was like a competition for who could be the biggest, starting in high school. Everyone wanted to be the biggest kind of guy in the club. And so, you had 20-year-old kids just taking, multiple types of steroids at once. And they would blow up, man. They would get huge. But then, I've seen some of these people later on, and they have, I'm not sure the exact correct terminology, but man boobs, right? Or other types of side effects or things of that nature. So presumably they were going way over the limit, you'd say.
Well, here's what's important to distinguish there is you mentioned, I'm presuming you're talking about some of these guys doing anabolic steroids. And unfortunately, we misuse the term steroids, which again, I think I've said it too many times already, but these are naturally produced substances made from cholesterol. We're talking about testosterone, estrogen, DHEA, even vitamin D, which is actually a steroid hormone. And there are other corticosteroids. People think, cortisone, cortisol, those are also steroids. But anabolic steroids are testosterone-like molecules, okay, typically DHT derived or testosterone derived or something close to that molecule, where you've added a ligand or removed one so that it acts differently, mainly to leverage accretion of muscle mass, but in other respects, pretty similarly to the androgen testosterone. It gives you the energy, libido, that sort of thing, with some caveats to each one that has a different profile. But the important thing to note about anabolic steroids is they all, it's rare you can say this in medicine or in life in general, all of them come with a decreased HDL effect as well as to increase LDL. Okay. So yeah, you could see guys having issues. And of course, when they're using these extreme amounts, I think to your point, gynecomastia, the man boobs, can be a problem because you're not controlling some of these metabolites. And so, yeah, you're getting all this testosterone, but you're also getting in typically equal proportions, at least, estrogen, and you're growing boobs and you're getting moody and irascible. And that's the other thing. A lot of people say, and you might be coming up with this question next, I'm going to see if I can beat you to it. What about, some of these negative side effects that are attached to testosterone? I see these guys in the gym that put 30 pounds on in 3 months, and half of it looks like it's in their face. They're holding so much water. And they went from a regular guy to a jerk, Dr. Jekyll and Mr. Hyde. Typically, it's not the profile of the anabolic steroid. Although there are some that are well known, like halotestin, which stay away from. But for testosterone, certainly, let's leave the anabolic steroids aside. It's the feel-good hormone. I said earlier, it's nature's antidepressant, and it gives you confidence. What happens when you have confidence? Typically, if you're not already a jerk to begin with, if you're a regular guy, you're like, well, I don't have to be on the defensive when that guy insults me in front of my girlfriend to make himself look better in front of her girlfriend or whatever. You take it in stride. Okay, whatever, man. It's his good. Let's let him have a good day. I don't want to bum my day out by getting in an argument here. So it does the opposite, in other words, of what people see with either anabolic steroids that aren't done properly or testosterone that's not done properly, specifically not modulating the estrogen, which when in excess, whether it's male or female, but certainly more to the effect in males, because we're not built for big swings in estrogen for reproductive purposes like females are. But even some females have issues with the swings in hormones, right? They call it PMS, or PMD would be worse. And so with guys, it can be disastrous. You're holding water, you're holding fat, you're getting moody and irascible. And of course, we have the issue of estrogen sensitive cancers. one of which is prostate cancer. There's some estrogens that we know can initiate cancer in the genes we all carry as men. So, all right, I'll stop there. But I hope
this is great information, by the way. This is like everything. I'm glad we're gonna, this is gonna be the episode. All things kind of like hormone replacement therapy, real deep dive. I'm sure the questions I'm asking are the same ones that a lot of the listeners are thinking about. So, in terms of concerns, actually, that's another one, is that a lot of people might think, oh, well, if I do testosterone replacement therapy, is it going to increase my chance of getting cancer? Or I think other rumors were something about heart health, right? Is it going to give me heart problems or things of that nature? What do you say to concerns like that?
Well, first I got to give credit where credit is due, and I'm probably going to leave some people out, but there are guys before me that worked a lot of this out, that they just didn't get as much of the so-called airtime, as it were, to get the word out. The most recent would be Dr. Lipschultz out of Baylor University. Before that, we had, these names will come to me. They deserve to be mentioned. Dr. Lee, the one out of the Tacoma Clinic, whose name is unfortunately escaping me right now. But there are, and even more recently, Dr. Morgenthaler, he's associated with Harvard. He was part of an international consensus of about 20 or so urologists who passed 9 resolutions. Actually developed 9 resolutions. It was published, the conference was in 2015, but it was published in the Mayo Clinical Proceedings in 2016, and it very well so demolishes what I call the propaganda that I think you're referring to. And we've all heard with testosterone replacement and other hormones, but mainly testosterone, very specifically. So I would start there. But there's a lot of misunderstanding regarding testosterone. For example, one of the earliest ones was it's the cause of prostate cancer. Well, actually, even though it was a small study, an N of 15, it has been used in what we call bipolar therapy to successfully treat prostate cancer. And again, if you have extant prostate cancer, then a metabolite of testosterone, not testosterone itself, a much stronger androgen, dihydrotestosterone, can fuel the growth. It's like pouring gasoline on the fire. But you can see how the mistakes could be made because we just didn't have the knowledge back then. Plus, we didn't even know how to do a proper study. A lot of stuff was done. For example, there was a study with testosterone where there was an N of 3 people, and they made conclusions that became dogma for 70, 80 years. And they look back, first of all, 3 people does not a study make, but 2 of them in hindsight should have been excluded from the study. So it's basically one person. So there's a lot of that lasted for a long time, unfortunately. But that's why I don't want to focus on that so much as, the consensus is a great way to start. Actually, Morgenthaler's book is a great place to start. Testosterone for Life. He explains some of these things away. So, and there's plenty of information out there that if anyone really wants to get down to the brass tacks of it, they can. Now, you'll still see some old, and that's the key. You got to look to make sure that the stuff that you're reading wasn't printed in 2002. But in general, we know now that there's a correlation between low testosterone and things like coronary artery disease, type 2 diabetes, colon cancer, prostate cancer, osteoporosis, to name just 5. Not the way it's been described to us up until, say, a decade or so ago.
Yeah, I mean, to me, it kind of makes sense, right? If you're have more energy, can exercise more, recover better, feel better, be in a better mood, you're probably gonna, potentially have less, disease and sickness in your life. So, definitely makes sense. And I think, again, I also think that, like what you said earlier, it was a really good point, really good distinction, is that, we take all these anabolic steroids and like everything that everyone was taking over the years, and we just all lump it into the same category with, the testosterone replacement therapy that's being done today, which is actually, pretty different than a lot of the stuff that, the guys in my gym when I was 20 years old were taking, probably.
Very different. And one additional side note to that too is in that laboratory, as it were, of guys that are experimenting, or in that profession even. And I'm not bashing, but I want to be careful not to, but there are distinctions between the average person who just wants to get back to a fitness level that they had when they were 25, now that they're 55, and they've spent 30 years sacrificing a lot of that physical fitness because he or she's been working in a profession and raising children, and et cetera, et cetera. That very different than someone who may be working out in some form or fashion, for a living professionally, that's also doing other stuff. And this is where, you read about some of these people that died and their death has been attributed to even anabolic steroids. And you go, yeah, but you don't know the inside story. It's a lot easier to admit that for the family than there was recreational drug use involved or something else. So that I can say, I can't give you names, obviously, but I've seen that personally in both, people at different gyms, we'll say, out there, but also in practice. So yeah, there's a lot of still what I call propaganda out there. But if you look at the research, I mean, the cat's out of the bag at this point when it comes to true testosterone replacement therapy. And we're focused on testosterone because it does suit both men and women. And it is a sexy one. It deals with most people's complaints and things we like to carry on, like libido, long into old age. But certainly estrogen replacement is pretty sexy when it comes to a woman who's suffering from hot flashes and night sweats every day and night, and eventually actually vaginal dryness, which makes all the fun stuff that testosterone can provide a non-issue because they can't enjoy intercourse. And then there are other hormones that aren't so sexy that can help us with cognition and color appreciation, like pregnenolone. Progesterone can help you sleep at night. A lot of people have trouble either falling asleep or staying asleep. And progesterone, when it's taken orally, can help effectuate changes on the GABA receptor, the same one that can be activated with, or at least a part of it, with benzodiazepines like Valium and Xanax. Not nearly as powerful, but not nearly the side effects either. And the same receptors as alcohol, things that relax you is my point. So there's a lot out there that still needs to be absorbed. And I think we talked about this earlier. That's the purpose of what you're doing in large part, and certainly what I'm doing as well, to spread the word.
Yeah, absolutely. Absolutely. I want to touch on a couple more. This is great. This has been a great deep dive into testosterone. And I also want to talk about a couple other kind of really popular ones recently. I have a couple friends, and I'm curious what your thoughts are about this, because I've also heard a lot of different mixed reviews about Clomid. Right. And I think there's some people that obviously, like myself too, honestly, I'm not huge on needles, right? I'd prefer not to have to stick myself with a needle if I can avoid it, or have someone else stick me. And so when I heard a couple of people talk about, oh yeah, I started taking Clomid, or it also kind of has some other different terms, but similar to Clomid in terms of the name of it. But you kind of take a pill, and a couple of people I know, it's naturally, or shouldn't say naturally, it's increased their testosterone by, I guess, spurring the body's natural production. What are your thoughts on that?
So Clomid is an off-label, or is a drug that's used off-label for this sort of thing. And it's a great drug for a lot of people, but it's actually an isomer of two other drugs. One is enclomiphene. I know this gets a little confusing. And the other is zuclomiphene. And for a lot of us, and I'm saying us because I was one of them, the side effects of the zuclomiphene isomer are unbearable. We're not sure the exact mechanism by which it works, but it can make you miserable, homicidal, actually more suicidal, if anything, really depressed. And so it comes with a price if you're using it for fertility, for example. And it's not used for what we call primary hypogonadism, where you're old enough, or for whatever reason, the testicles are no longer functioning. This is secondary to the pituitary not sending a signal to the testicles when we're using something like Clomid, or HCG, which you might have brought up also, human chorionic gonadotropin, which is what we call a homolog, not even an analog, because it's so closely related to luteinizing hormone, which is the substance that's released by the pituitary and goes to either the testicles or the ovaries and tells them, hey, produce some testosterone. So you're in kind of a gray area if you're in the 30s, or I think you said your early 40s,
Yeah.
where it may or may not work to treat it as secondary hypogonadism. But that drug, along with HCG, is used for getting your, and yeah, like you said, I said definitely nothing natural about this, but it is getting your endogenous production up and running again. It's a good first trial if you're not too old, where the odds are against you. Although, as I said earlier, I'm a registered libertarian. So if you wanted to give it a try to see if you can get your own testicles or ovaries going, I think it's great. And you'll know pretty quickly. You'll know within weeks. So it's not like a year commitment or something. And then if that doesn't work, you can switch to treating as primary hypogonadism. But in that way, you can also preserve fertility, particularly for a male. That's a concern. Although I would argue this goes back to the propaganda where, oh, if you ever go on TRT, well, you can forget about having kids. I've heard if you ever do anabolic steroids, forget about it. Well, again, very quickly and easily, I go back to that example I used with, oral birth control for females. It's just not the case. It's something as soon as you go off of it, and thanks to Dr. Lipschultz, he's figured out a way to continue TRT and restore fertility at the same time. So it's not miserable having to choose between, going back to low T just to have kids or not.
Yeah, but yeah, that is my concern too, because I was again not the ideal source of information, but it was at least watching videos of different doctors on YouTube. But some of them were saying about Clomid and these potential side effects of it causing depression or whatever the case may be, in some cases, and then other people said they do give it to their clients in some cases, and so yeah, it was kind of interesting. But I have heard of a couple of people recently, I guess probably similar to my age, right? Age 41, and having decent, again, right? Like I have, I guess, halfway decent regular testosterone levels, pretty low on the free lower than I'd like to be on the free testosterone. So that's something that I was kind of thinking about. But then when I heard, I'm like, well, anything that's going to cause me depression, I don't want to try that, So that was my concern with that one.
Well, I should have gone further to say that we've isolated the isomer enclomiphene as of 2015. And so that can be used off label now. It has to be compounded because it just wasn't made. It's not worthwhile to go through all the other approvals necessary to bring it to market as a brand. But through a compounder, I would definitely try that because you get all the benefits of that you want from Clomid, the brand name. It's called clomiphene citrate. I know it gets confusing with the names, but anyway, enclomiphene is what you should consider trying to avoid the potential side effects and get the results you're looking for. And again, you can also try HCG, but then you're using that needle again and having to refrigerate it and mix it usually and all that kind of stuff. So the enclomiphene is actually a good first choice for anyone who wants to give it a try to see if they can get their symptoms resolved using endogenous production. And I'm just emphasize that one more time because I don't want it to get across that we're focused on the numbers because we keep talking about it and we can get lost in that. Well, 800, but only 11. Yeah, there are some parallels there you can draw where typically, 11 is people are going to be complaining, in their 40s that that's just not enough. But it starts with the complaints. Then we look at the numbers. So if you say, hey, we're talking numbers, and because this is what I do for a living, Rand, I get to see these numbers and whatnot, but I feel great. Well, then forget about it.
Right.
Wait till you're not feeling as, again, that decrease in whatever it is we're talking about. And then it makes sense to go to the doctor and say, hey, is this something that I could try?
Got it. Okay. So enclomiphene how's that spelled exactly in the beginning?
E-N.
E-N. Okay.
Yeah, and then clomiphene. Yeah.
Enclomiphene. Okay, that's a great distinction. Great to know. Well, great. Well, I know I want you to tell people a little bit about your upcoming book here as well. I know we only got a couple minutes left, so I want to make sure we talk about that because it's got an incredible book title, and you're kind of walking the walk with the title of that book right now. So yeah, tell us a little bit about kind of what you cover in that book.
So with COVID came that, third day of having a beer at 1:00 and getting sunburn up where I live in the hills of Malibu. And I thought, okay, this is not cutting it for me. I got to do something besides this. So thought, well, what can I do to, and we were talking about this earlier, you and I just want to spread the word. There are so many cool things that we have available to us that certainly when I was a kid, this wasn't even considered, it was all sci-fi stuff, right? But we have ways that mainstream medicine, in the sense of, the business of medicine, HMOs, I call it paint by numbers medicine, it's not going to be provided. And in all fairness to that section of the business, you can go to, and I think MD Anderson is one of the top institutions in the world, okay, for treating cancer. But because of the business of medicine, you can find out about a treatment and say, well, hey, why can't we use this one? I think based upon my research, this is better. They may actually look at you and go, yeah, you're right. It might actually be better. But this is the way we do it here. You're like, oh, wait a minute, man. So again, as a registered libertarian, but also as someone who wants the ability for not just me, but all of us to have the choice to say, well, yeah, but I feel more comfortable with this option. This resonates with me better, to at least be able to express it, to know about it. And so the idea of the book, behind the book, is to, again, spread the word about all the options. And that's not all of them, certainly. I mean, I can't tell you about what a surprise it was writing a book, because I wanted to present so many other things. And they call it, there's a term for it. They call it killing your babies. They go and they go, nope, not gonna, no one's gonna be interested in that. That's too complicated. So it's a pared down version, but I think it's pretty extensive nevertheless for people that want to find out, what can I do other than just ask my doctor, who will look at me like, no, you're good. Or, my favorite is, no, there's nothing wrong with you. Really? Why did it come all the way down here and express to you that I don't feel the same as I did when I was 20? Oh, you're just getting old. Nothing you can do about it. This arms the average person, anybody, with the ability to say, really, well, what about stem cells? Well, what about rapamycin? What about these different supplements? How about these alternatives? So again, I'm sorry, I'm rambling here, but that's the
No,
point.
it's great.
Is to inform people about our choices and what's available to us to live a better life. That's all.
Amazing. So called Cheating Death, is that right?
Yeah. Yeah.
Cheating Death. Is there a website or a place where people can kind of pre-order or get on the list to be notified?
I think it's all in all the sources, like, Barnes and Noble and whatnot, but I know, because I'm a avid Amazon user, I know for sure it's there.
Okay, it's already for sale now. It's already for sale,
no,
right?
they call it pre-sales at this point. It'll be released
Okay,
March 7th. But you
great.
can buy now and have it sent, with Amazon Prime within a day after it gets out, I guess.
Amazing. Yeah, we got so deep in the hormone that we didn't even get to talk about stem cells and rapamycin and all that other fun stuff, which are really well known as well now. I mean, stem cells for healing, and rapamycin is actually actually, can you break it down? Because I keep hearing about it as such a powerful anti-aging drug. You mind if we spend a minute just telling me about that one?
Look, if you haven't figured it out yet, I can talk about this all day long. I don't want to bend your ear and bore your audience too much, but rapamycin is very exciting, because a lot of what we know about aging now, and I think we all agree, there's not one mechanism, there's multiple mechanisms. But for example, David Sinclair has gone into detail about, it's all about information. Again, I shouldn't say all about, but a major part of his information, the DNA, and it getting corrupted or not, and getting it repaired. And then, it flows into, well, if you can't tune the car, then instead of letting it run with the exhaust spewing everywhere and affecting those around as well as the driver, then you have to at some point just bury the car. You have to shut it off and reuse the parts, so, a process we call autophagy. With that in mind, rapamycin gets involved through, they actually call it mTOR, the mechanistic target of rapamycin. But there's two complexes we've identified, mTORC1 and mTORC2, and I'll make it not so complicated, but we want to tamp down on mTORC1 considerably to allow that process to take place, where I liken it to a kitchen where you've got a recipe book out, and you've got your pots and pans, and you're slinging food because you're busy and you're doing stuff. And well, there has to be a time where at the end of the day, and there's a process that happens every night that approximates a lot of this and takes care of business. But you got to get the spaghetti sauce off the recipe book so you can see it's 2 ounces instead of 3. You got to clean the pots and pans so you don't cook with what's eventually going to be rotting pan contents when you're trying to make good fresh food. So again, you're setting the cell up to function the way it was intended to with all the right instructions. And if not, get rid of the cell and recycle the contents. And this rapamycin and the tamping down an mTORC1, and we believe now that we don't necessarily want to tamp down an mTORC2. So we're either going to use rapamycin with another therapy that does just that, or we'll find what we call a rapalog. Now they're talking about something that works kind of like rapamycin. It might be a totally different drug, and I touch on that a little bit in the book too. But so that we get the effect we're looking for, which is to tamp down on mTORC1 and either hold mTORC2 or increase it, and we're going to get the best of both worlds, and presumably, in a pretty big way, extend our health span. Again, that quality of life with longevity, and that's the basis for a lot of the latest theory on aging. When we look at centenarians, the people that live a long time, it's staving off this natural process that occurs, right? You know, the breakdown of information, the recipe book gets contaminated, however you want to put it, which occurs in all these people, but it occurs later. It doesn't happen, you know, until 10 years, 20 years, even 30 years later to these centenarians. And if we can get just that, we get back in there and clean up the cell so we don't get disease processes going earlier, we've just done our job. We used to call it in the old anti-aging days, you know, squaring the curve. So instead of, as you put earlier, you know, spiraling into old age, we keep going, and there's one day, okay, run out of gas, so to speak.
Right. Yeah. So rapamycin. So right now it's prescription only, right? You can't get it like over the counter, right?
It's prescription. It's also not cheap, but I would argue it's worth it. And what's cool about this drug too is even the skeptics, the people that are, and you know, the red team, I call them, you know, the ones say, no, we don't have enough proof yet. And I love those guys. Even they are doing it, even if they're not recommending to their patients, although some of them are, because they realize, no, this is just, I mean, how are we going to poke a hole in this when it just seems so obvious? We just don't have the gold standard study yet. And by the way, how are we going to have those other than, you know, mice? Because human lifespan is so long. So it's going to take a while before we have the definitive proof anyway.
Right. So right now, I know, yeah, Sinclair, I've heard mention that he's doing a lot of work on it with mice, right, in his lab in Harvard, rapamycin. And so is that one? So are you taking rapamycin? Like do you prescribe it to your patients? Are you able to?
I do, and I do.
Nice. And is it something where it's just kind of like known as an anti-aging, it's worked in these studies on mice so far, and it's going to increase our long, you know, health span, which is, you know, healthy lifespan. Is it something that you feel like, do you feel more energy with rapamycin, or is it just kind of like a long-term kind of anti-aging thing?
First, I'm not sure if Sinclair is working directly with rapamycin. I may be behind. I read his book about a year ago and I haven't kept up, so I apologize. I just don't want to have people go the wrong direction that I don't know for sure. He's working with the sirtuin genes for sure, but what mechanisms he's used to, you know, turn that on or off, I don't know. But the gentleman, the doctor who's done a lot of work, I think I'm patient number 900 and something, is Dr. Alan Green out of New York. He's an internal medicine doctor, very knowledgeable in this area. Great guy, by the way. Have to say it, he is. And he would be the one, I would refer to if someone, you know, we're going to go through the process without me. And there's other doctors out there. I mean, have fun getting to see Dr. Peter Attia. He's got a long waiting list. But guys like that, you know, which I consider leading edge, are doing it. There are some rules you have to pay attention to. You want to make sure blood sugar levels and insulin sensitivity is where it's supposed to be. So you don't just you know, prescribe it willy-nilly. And there are some potential side effects. I have seen only one side effect, and that's canker sores in a peer of mine, a doctor friend. And then he just backed down on the dose very marginally. They go away. And Dr. Green will tell you, look, have a Z-Pack on hand in case something catches on. But you know what's interesting is that the more we look at it, the more, especially at this dose and with the dosing pattern, which is not consistently every day, and it has to do with going back to that mTORC1 versus mTORC2 and how much you want to tamp down and for how long. once a week dosing at the current time looks like the best way to do it, but it really doesn't look like it's affecting your immunity the way we thought it would. I mean, because it's used as an anti-rejection drug for, say, kidney transplants. And I think that's going to be eye-opening when we can find out more about the real way that works, the mechanisms behind, not just rapamycin, but that whole system, the mTOR system works. And then to your other question about does it make you feel any better? Dr. Green said to me that a lot of his athletes, because I told him, "Hey, look, man, I'm climbing Mont Ventoux. I need every edge I can get. I'm not exactly built like a bicycle rider, certainly not a climber. Is this going to hamper me?" And he says, no. A lot of his endurance athletes seem to notice an improvement, and it makes sense. If you're fixing the machine, no matter how you fix it, things should get better. But also, I notice when I take it, I feel like I get a burst of energy for a day or so.
Interesting. This is great stuff, man. We could go on all day, and in your book, you do go on for much longer. So I encourage everyone to check it out. Cheating Death, pre-order it on Amazon. March 7th is the release date. And Dr. McClain, thank you so much for you spreading your knowledge here with us, with our community here today. There were a lot of questions. Obviously, you could tell that I have, and that many of our members in the community have had. And I think you've really done a great job of explaining and breaking it down. All things kind of hormone replacement, and we even touched on rapamycin there as well at the end. So really appreciate your time. Thank you so much for everything you do and for joining us here today.
Well, it was a pleasure for me, and I hope that came across. And anytime you want to do it again, I'm all in. So thank you for having me.
Sounds great. We will.
All right. Thank you, sir.
Thanks for listening. And just a reminder, if you haven't yet tried any of our Peak Performance products, you get 20% off your first order. We have one of the largest selection of USDA certified organic superfood powders, as well as very high quality supplements. And you get 20% off your first order at buypeakperformance.com. That's www.buypeakperformance.com.